Hello, and welcome to our live webcast, Elbow and Wrist Pain in the Everyday Athlete. Thank you for joining us. My name is Megan, and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we ask that you complete a brief post-event evaluation. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. We are joined today by our speaker, Dr. DiPrinzio, orthopedic surgeon with Atlantic Medical Group and is fellowship trained in hand and upper extremity surgery. And at this time, I'd like to turn the microphone over to our speaker for opening remarks.
All right, thank you, Megan. My name is DiPrinzio, and I'll be talking about elbow and wrist pain, everyday athlete. I think I'm just going to go ahead and get started. I have a couple of introduction slides. So I have no disclosures for this talk. Just a little bit about myself. I recently joined Atlantic Health System, and I'll be seeing patients in Wayne and Paramus, and I'll be at Chilton as well. I am a New Jersey native, so I'm happy to be back in the area. I did most of my education in undergrad and medical school at Rutgers in New Brunswick, and then I did my orthopedic training at Mount Sinai and my hand, wrist, and elbow fellowship at Duke. And happy to talk about any upper extremity or other questions you may have. This is my email here, which is best to reach me at. All right. So just a quick outline for today. This is primarily geared towards primary care physicians and others that might be evaluating wrist and elbow pain in the primary care setting, but I think it's applicable to anyone who's looking to learn a little bit more about diagnosing and treating elbow and wrist pain. So primarily I'll be talking about tendinopathies and arthritis just because I think that's what presents kind of in this subacute and chronic setting that you may be seeing. I will not talk much about surgical treatment, although when I do, it's just to give a complete picture of the pathology so that we can have better conversations with our patients and also with each other to have a good understanding. I won't talk much about acute trauma, fractures, and ligament injuries. I won't talk about the high-level athlete population or pediatrics, and I won't talk about PRP injections. So we have a few polling questions to start just to get an idea of our audience here today. So the first one, I feel more comfortable diagnosing and treating wrist pain, elbow pain, about the same for both, or not very comfortable with either. We'll give it about 5-10 seconds. All right, great. So I think, it seems like everyone is in the right spot. So we'll be talking about both today, and I certainly think that wrist pain can be a little more difficult. So we'll get to that in a second. So the second question is my level of comfort with wrist corticosteroid injections. A, comfortable. B, some comfort, but would like to learn more. C, do not or rarely perform them, but I'm interested. And lastly, I don't do these in the clinic. All right, give it a few seconds again, so close. Good, so I think that hopefully after today's talk, some more people will feel comfortable with doing these at the appropriate time. So like I said, I'll start with wrist pain. I think it's just a little more difficult to treat if it's something that you don't see every day. And I think the diagnosis and treatments can be a little more variable depending on where they're having pain. So some problems that I still experience with wrist pain, I often find that patients come in with generalized pain, and I'm kind of doing my detective work to narrow it down to what actually might be going on here. I think sometimes patients can only reproduce the pain with certain motions. They might not have it at rest or on your exam. The anatomy is fairly complex, although I do think just knowing the pertinent anatomy is very reasonable and very helpful in trying to make a diagnosis. And lastly, just like any musculoskeletal issue, patients are often looking for immediate answers and to get back to their regular life quickly. So for wrist pain, I think that you do have to be a true diagnostician. The history does matter. You have to figure out what type of activity is causing their pain, maybe what position or what motion might be doing that. I think that's very helpful. In terms of the examination, it's all about narrowing that down to what point of their wrist is really giving them the most trouble. And then imaging, in orthopedics, I understand that imaging is part of our primary workup, but that might not necessarily be the realities of a primary care setting. So when I talk about imaging and when I think it's appropriate to get an x-ray early in treatment, it's just to give you an idea of patients that might benefit from getting an x-ray early rather than just initiating treatment. And the reason for that is, for whatever reason, especially in the wrist, it seems that acute injuries might get away with minor presentations initially, so minor that a patient might not even come to the doctor, and then they ultimately present as a chronic issue. The good thing about these is that in terms of arthritis or maybe a chronic non-union, it's still not a surgical urgency or emergency, so sending these patients out for an outpatient x-ray is not going to change the ultimate treatment course. So the way that I like to break down wrist pain is by location, and it's just my systematic way of narrowing down a rather broad diagnosis quickly. So by location, I mean ulnar side of the wrist, the radial side of the wrist, the dorsal or back of the wrist, and the volar or palm of the wrist. So I'll start with ulnar-sided wrist pain just because I think this is something we see a lot in the recreational athlete, and it can be something that's frustrating both for the clinician and the patient if you can't figure out or pinpoint a diagnosis and get them on the right treatment path. So when I start to think about ulnar-sided wrist pain, I immediately try to break it up into two main pathologies, that being ECU tendonitis or extensor carpi ulnaris, or that being a pathology within the ulnar side of the wrist. I'll call that foveal pain at times in this presentation, and really that could be a TFCC or an inflammation of the joint capsule, what we call synovitis. But really I group these two together because I treat them the same. So I'm trying to break it down into these two categories. In terms of history, I find that tennis is the biggest offender in terms of the sport that people are playing. And as you can see from these two images, there's just this unnatural ulnar deviation and twisting motion that's required to hit a tennis ball with a racket. Patients will also usually come in and demonstrate this generalized pain over their ulnar wrist. In terms of the pertinent anatomy, and I think this is especially important for your exam, the ulnar head is really the lighthouse of the ulnar side of the wrist. So that's the first thing that you'll notice, the first thing that I palpate on the exam. And the reason for that is because it leads you to finding these other parts of the ulnar wrist. So the ECU tendon runs up the forearm, runs through a little groove at the ulnar head, and then on to its insertion at the base of the fifth metacarpal. And it's really felt best or palpated best just distal to the ulnar head. The ulnar fovea, or the ulnar wrist joint, is where you'll find the TFCC and the wrist capsule, and I'll talk about that more in a second. So again, for the ECU tendon, it's felt or it's palpated distal to the ulnar head. And I think one big tip and one trick that helped me when I learned it was that people with ECU tendonitis will typically have pain where that tendon inserts, which you can see is fairly distal, which is this more distal arrow here. So that can be easily differentiated from the foveal pain, which we'll talk about in a second. So people that have pain in the ulnar fovea, they may have an issue with the TFCC or the ulnar joint capsule. And the TFCC has some complex anatomy, but I really think of it as the meniscus of the ulnar side of the wrist. And that's helpful when I'm explaining to patients as well. And then the capsule you can see down in this bottom image kind of goes all the way around the corner of that ulnar head. And when you have inflammation there, it can really cause some significant ulnar-sided wrist pain. So when I'm palpating for the ulnar fovea, I actually turn their palm up, and I will locate that ulnar head over the side of their wrist there. And then I'll dip my finger just distal to that, and that very reliably finds the ulnar side of the wrist or the ulnar fovea. So I like to differentiate that pain from the ECU tendon pain, which again is going to be a little more distal and on the other side of the hand. So that's my main way of differentiating these two pathologies. And I have this arthroscopic image here just because I think for patients and those that may not be seeing the inside of the wrist very often, synovitis can be a difficult diagnosis to picture. And really what that is just an extreme inflammation of the joint lining. All of this tissue should just be white, just like the capsule or the wrist ligaments. And you can see it's all red here and really causing some significant problems. In terms of provocative testing for the ulnar side of the wrist, I don't find these as useful as some of the other ones I'll talk about later today, but if you're looking to buff up on your wrist exam or you're still trying to differentiate between the two pathologies, you can certainly try these two maneuvers. The first being the synergy test, which is specifically for ECU tendonitis. So you have the patient hold up their hand like they're doing here and spread their fingers out, and then you'll grasp the middle finger and the thumb and have them radially deviate away from their ECU tendon. And that really causes a lot of pressure over the ECU tendon seen there, and pain during that maneuver would lead you to that diagnosis. And then in terms of the TFCC, or the ulnar side of the wrist, this TFCC compression test or grind test can be helpful. So you have the patient hold up their hand, and you'll grasp their hand and ulnarly deviate it, and then you'll kind of move back and forth in a semicircular motion, grinding along that TFCC. So you'll pull the wrist down and kind of go back and forth. And eliciting pain during that would give you a clue that that might be what is causing their pathology. So on to treatment. And although I do break these into two pathologies, I like to treat them initially very similarly. So I like this brace called the wrist widget, and sometimes it will be in your DME, and sometimes you may have to direct the patient to purchase it independently. But I like it for a few reasons. It stabilizes the ECU tendon and the ulnar side of the wrist as well as the ulnar head. It gives a little bit of a compression effect. It limits the motion just enough where you're probably taking some pressure off of that ulnar side of the joint while still allowing them to do an activity such as tennis. And it's pretty low profile. So if you have a patient who's just having pain while playing tennis, this might be a great option because you can say, hey, just wear this brace while you're playing tennis, and hopefully that'll resolve the pain. Occasionally, I will perform a corticosteroid injection at the first visit, which I'll talk about in a second. And occasionally, I'll just go ahead with this volar wrist brace, more typical for carpal tunnel or wrist sprain, if a patient is really in significant amount of pain, especially if it's constant pain and not just during their activity. And I'll do that for a minimum 6 weeks. And then I'll see them again at 6 weeks, and if they're still having trouble, likely I'll perform a corticosteroid injection at that time. Maybe I'll move from the wrist widget to that volar resting brace, and I'll try to give them a full 3 months of conservative treatment before taking any further steps. In terms of that ulnar-sided corticosteroid injection, so this is where that differential diagnosis really splits off. So for the ECU tendon, I'll try to inject just along the tendon. So typically that's at this darker blue arrow, a little more distal along the wrist. But sometimes patients can have pain closer to this lighter blue arrow, a little further up the forearm. I don't mind giving the injection there either. And then you have the ulnar-sided wrist injection, which is seen by these two light green arrows. So I prefer to do the injection over here on the side of the wrist. I do think this is acceptable and very easy if you can see that ulnar head popping out when their hand is pronated. But again, I like to have their palm up in the air. I'll palpate for the ulnar head and slide just distal to that. And you can see that's kind of along this wrist flexion crease. And then I'll inject directly in there. It's a very safe place to give an injection because the ulnar neurovascular bundle is going to be here and it's going to be much more superficial. So as long as you're using the ulnar head as a guide, like the lighthouse of the ulnar wrist, you'll be able to give that injection fairly easily. All right. So next steps, just to give you an idea. So at that 3-month mark, what I'll usually do is order an MRI arthrogram or MRA to confirm the pathology that I suspect, and then likely they would need a wrist arthroscopy to address that inflammation or TFCC, and occasionally I'll perform an open ECU tendon debridement. So on to dorsal wrist pain. So the sports that seem to cause this in patients are the sports that require a hyperextension of the wrist while weight bearing at the same time. So certainly gymnastics can do that, although you may not be seeing that in a recreational athlete. More likely it's going to be yoga, it's going to be push-ups and bench press. I see this a lot in patients who like cross training or CrossFit. So and I also want to explain that what I'm going to talk about here is really the insidious onset event. So this isn't really a wrist sprain or a patient fell and all of a sudden their wrist started hurting. This is, I do this activity and over a period of time, weeks or months, I start to develop this issue with my dorsal wrist. Often patients will show you directly over their wrist as the cause of pain, and they'll probably even extend their wrist as you're talking to them just to show you what's going on. In terms of what this is, I think that over the last 10 or 15 years, we've really come up with this term dorsal wrist syndrome. And the main culprit of that dorsal wrist syndrome is actually the dorsal capsule of the wrist. So it's getting inflamed, it's becoming a little bit more thick than it typically is, and it's causing impingement along the bony articulation of that dorsal wrist. Sometimes the bones themselves can be a problem, so you may have some bony abutment, but again, I really think this dorsal capsular impingement is the main culprit when you have patients telling you about this problem. In terms of the anatomy, I don't think it's important to get into the woods about which ligaments are on the dorsal wrist. It's just good to have an idea that there is this thick capsular and soft tissue layer over the dorsal wrist, and any thickening of that capsule will really cause an issue when patients try to hyperextend. In terms of the bony architecture and what this right-sided image is showing is that occasionally there will be some underlying issue with the bones that may be contributing this as well. I wouldn't necessarily treat that differently in this chronic setting, but just so you're aware, this is what we call an ulnar-positive wrist, or a wrist with a long ulna, which may be contributing to some dorsal wrist pain. In terms of the exam, very reliably you'll find point tenderness over the dorsal wrist. Often or almost always they'll have pain with wrist extension. They may even show you pain when they try to hyperflex their wrist down, and they'll have pain over their dorsal wrist again just from stretching out that capsule. Here are some red flag things that I don't think you'll find in dorsal wrist syndrome. So these ones in orange. Typically there's no crepitus or locking with their motion. There's not a large loss of their motion. So yes, they may lose a little bit of wrist extension, but in the grand scheme of things, compared to the other side, it looks very similar, especially with radial and ulnar deviation. You really shouldn't see any change with that with dorsal wrist syndrome. If these are popping up with your patient, I hope that's setting off some alarms in your head, because probably what's going on here is more of a chronic bony issue, maybe arthritis, maybe it's like that scaphoid or like that scapholunate ligament now rearing its head in a chronic setting. And secondly, like I mentioned a couple minutes ago, dorsal wrist syndrome is really insidious onset over a period of time. If you have a patient who told you that they had an acute wrist injury, even if it was 2 or 3 months ago, I would likely opt for an early x-ray there just to make sure that I'm not missing anything. In terms of treatment for dorsal wrist syndrome, I do like to do a corticosteroid injection early in treatment. I think for a few reasons. One, I do find it very helpful just in treating the pathology. And secondly, I think it's very helpful in just confirming your diagnosis. So this is a therapeutic and diagnostic injection. I'll also give them this volar wrist brace, and that's very helpful with preventing them from doing that wrist extension moment. The good thing about treating recreational athletes, especially if it's cross-training or yoga, is they can usually find some maneuvers or positions to wear this brace and still work out. So I really think it's important to avoid that inciting activity for at least 6 weeks. At the 6-week mark, if they got any improvement from that first injection, I'll likely give a second one, again for a full 12 weeks of conservative treatment. So dorsal wrist injections, this image on the left is for wrist arthroscopy, but I think it's helpful in just figuring out where you should be giving these. So that 3-4 portal is the main target, but you can see this central area of the wrist is very open to giving wrist injections. So the way that I as a hand surgeon was trained is to find Lister's tubercle, which is a bony prominence over the dorsal wrist, and then you go about 1 centimeter distal to that and you'll find the right area. Now, in training, I did not find this very easy, so I kind of came up with my own way of figuring out where that wrist injection should go, and I use the bigger bony prominences around the wrist. So the ulnar head is almost always palpable, and if you look at where that ulnar head is, it's actually in line with Lister's tubercle. So that right away will give you an idea of where that bony prominence may be, and my injection should be distal to that. Secondly, I'll look for the radial-styloid, again, a very large bony prominence. And if you look again, that radial-styloid is pretty much where that wrist injection should go. So now you have two really easy ways to palpate along the dorsal wrist where that injection is going. And then lastly, where should this go, radial or ulnar along the wrist? Again, if you can't feel blisters, I've found that this kind of valley between the index and the middle finger knuckles is a really good way of finding where that should be. Obviously, that can change with radial and ulnar deviation, but I do think it's very helpful if you're still looking for that spot. And if all else fails, look for that ulnar head, know your injection is going to be distal, just look at the wrist and find where that center line might be and go just radial to that. I think that all of these clues can really help you along with putting that injection in the right spot. And then in terms of next steps for dorsal wrist syndrome, again, I opt for an MRI arthrogram just to confirm the diagnosis, and then I'll perform an arthroscopy, really getting rid of that redundant capsule. You can see here that there's just way too much capsule within the wrist joint, and it's actually inflamed as in this picture. So getting rid of that is very helpful in treating these patients, and patients typically have very good outcome from this surgery. All right, on to radial-sided wrist pain. So these are some pathologies that I think most of us are going to be very familiar with, so I won't spend as much time here. But in terms of radial-sided pain, again, I like to break it down into Decker veins and thumb CMC arthritis, so identifying which one is probably offending the patient here and go along with that. In terms of the history, Decker veins, activity-related, sure. I've seen almost any sport cause it, including weightlifting, tennis, golf, baseball. But especially just everyday tasks seem to become annoying, lifting pots and pans. Of course, the old eponym is from new mothers. And you'll find that patients have pain with resisted radial deviation, often pointing directly to that radial styloid over that part of their wrist. And then in thumb CMC arthritis, really the issue is with gripping. So any sport that uses a club, a bat, a racket will likely cause symptoms within the thumb. Again, many everyday activities, just like buttoning their shirt, opening bottles and jars, will also cause pain. Patient often demonstrates a little more generalized pain. They're not easily able to palpate it. It's deep within their hand, sometimes even within their palm, and it's a little more distal than what you would see in Decker veins. So Decker veins anatomy, this is the first dorsal compartment of the wrist. There's two tendons, the APL and the EPB, that run through there. So the abductor pollicis longus and the extensor pollicis brevis. They become inflamed going through this small little area. Sometimes you'll actually feel a palpable cyst on their exam as well, which can be normal for this pathology. I like the Finkelstein test, which is demonstrated here. I find it very reliable. Get the patient to put the thumb within the palm and then actively ulnar deviate, recreating the pain. I find the first dorsal compartment easily palpable once you've found the radial styloid, which is a little misleading in this center picture, but it's actually that volar portion. And then just dorsal to that will be the first compartment tendons. You can run your fingers over them on the exam. In terms of treatment, I think corticosteroid injection is very effective for this. So that will be my go-to treatment for Decker veins. Wrist brace, I think, is good too. I think you have to be careful because I've experienced many times patients with Decker veins, especially acutely, will actually have more pain once they put this brace on just because it's pressing right on that area that's giving them the trouble. So I'll actually have the patient put the brace on in the office and see if it's causing them any pain. If it's helping, great. If it's not helping, then no brace for them. Or maybe I'll go with this lower profile brace just to limit their motion a little bit while not really putting a lot of pressure on that radial side of the wrist. I'll try another steroid injection at about 6 weeks, and again about 3 months before going on with more aggressive treatment. In terms of that injection, again, I like palpating the radial styloid. I think it's very reproducible on exam, and then just go just dorsal to that where that blue arrow is and give that injection. I find the patient is a good guide for this injection as well, so they'll almost tell you where their maximal point of tenderness is, and that's a very reliable way of giving the injection the right spot. We do talk about complications of corticosteroid injections all the time in orthopedics, but I do think it's especially pertinent for the Decker veins injection. I've seen both of these complications. One is lightening of the skin or depigmentation, especially and a darker skin tone individual. Usually that does improve, but I like to tell patients just the same. And secondly is fat atrophy, and you wouldn't necessarily expect that over the wrist, but there actually is a significant amount of subcutaneous adipose tissue there. And once that fat atrophies, it gets pretty difficult to keep injecting there. Usually those patients go on to surgery. That doesn't mean I don't give the injection. I just think that it's important to warn patients about these just because they're a little more common in this area. And then in terms of the next steps, first dorsal compartment release, very reliable at relieving their pain, fairly quick recovery. Usually at about 6 to 8 weeks, patients are feeling about 90% better, full recovery in about 3 months. And then on to CMC, again, something that you likely see very often already. Sometimes you can even see this CMC arthritis or this shoulder or saddle deformity here. I do like this CMC grind test. I think that's pretty reliable. You grasp the thumb and place an axial traction, and then I actually go in just little circles around the CMC joint, but this picture is demonstrating a pronation and supination movement. And either way, I think that's very good at detecting that CMC arthritis on exam. For CMC arthritis, I like to start with a brace. So before corticosteroid injections, I like to try and get them in some sort of immobilization. I like this hand-based brace. It leaves the thumb MP joint and the IP joint free. So just like the wrist widget, it can be used during most activities. Sometimes the patients just need a little bit more restrictive immobilization. Maybe that hand-based brace wasn't working for them. I'll go on to a more traditional thumb spica. I'll try that for 6 to 8 weeks, and if it's not relieving their pain or they're just still having pain through that brace, then I might consider a corticosteroid injection, but I typically don't jump to that right away like I do for the Decker veins. CMC injection, these can be a little tough as well. So what I like to do is palpate along that thumb metacarpal. So palpate along, make sure you're feeling the bone, and then you'll feel this little ridge right where that CMC joint is. Again, I think that if you're having trouble, what you can do is feel along that bone, and then right at that base of the thumb metacarpal, right at the border of the glabrous and non-glabrous skin, which we call the skin over the palm of the hand and the dorsum of the hand, you'll find a little opening for yourself to get that injection. I think that's especially helpful because it helps you avoid that EPL tendon shown in green here as it's running up the thumb. You'll always avoid it if you just skip a little towards the palm of the hand. Again, similar side effects as to the Decker veins, I don't think as common, but I think if you're not someone that does this very often, maybe it's your first time giving this injection, just know that it is a very painful injection. That CMC joint is extremely small, and even a very small amount of fluid injected will cause a lot of pain. So I warn patients of that. I typically don't give more than a cc, so maybe half a cc of steroid, half a cc of an anesthetic. I might not even give that whole cc. So just so you're aware, it's a very small amount of fluid. Warn the patient that it's going to hurt a little bit. It doesn't mean that you're not doing this right. And then in terms of next steps, people have been doing arthroplasty for the CMC joint for a very long time. All CMC arthroplasties remove the trapezium, so that's where this little space comes from, where that bone used to be. Maybe in the last 10 years, this technique has emerged. It's something that I use as well. So this is called a tightrope procedure, which uses a suture button suspension device. So you still remove that trapezium, but then you use this little device to suspend that thumb metacarpal. And what we found is it actually does a very good job at maintaining the space here, so maintaining that padding, so you don't have that arthritic bone rubbing on the scaphoid down here. And it also allows patients to move a little bit earlier along in their recovery. So I think that this changed the recovery period from maybe 3 or 4 months down to about 6 weeks to 8 weeks. It's been very helpful for that. And lastly, volar wrist. In terms of the wrist, volar wrist pain, I will say I'm about to talk about 2 tendinopathies in the volar wrist, but I do like to keep a broad differential diagnosis, and I'll talk about this in a minute, about things that are really what I call wrist mimickers. So although these tendinitis might rear their heads at some point, really keep a broad differential when you're evaluating volar wrist pain. So the FCU tendon, or flexor carpi ulnaris, and the FCR tendon are the main tendons running down the volar aspect of the wrist. I'll start with the FCU. So this runs along the ulnar forearm and inserts onto the pisiform, which is a small bone in the carpus. This is often associated with pisotriquetral arthritis. So you see this blue arrow here is pointing to that space, and you can see that over time that space may close down and start to cause some pain. So often FCU tendonitis in middle-aged individuals or older will be associated with arthritis there. FCR tendonitis, on the other hand, has kind of this bimodal distribution. So you'll see it in young patients, especially tennis players, and anyone that needs forceful flexion of their wrist with pain along that tendon. But you'll also see it in middle-aged and older individuals who are starting to have arthritis within their wrist. So maybe it's that CMC arthritis that we just talked about, or maybe it's this so-called STT arthritis at the distal aspect of the scaphoid. Either way, that FCR tendonitis is usually associated with arthritis in older individuals. Both of these, I will say, are relatively rare. I don't see them very often, and that's why I keep my differential wide open. If I do think it's one of these tendinopathies, then I'll put them in this volar wrist brace for 6 weeks. The workup after that gets a little complicated. I'll have to decide on which type of advanced imaging I want, an MRI or CT. These injections are a little more risky given that there's a lot of neurovascular structures around the volar wrist. So again, rare tendinopathies, at least start with a volar wrist splint, and we'll go from there if needed. So wrist pain mimickers, I have to say that these are probably more common, especially in the volar wrist, than those tendinopathies. So carpal tunnel syndrome, I know that it's not supposed to cause pain, but patients don't usually read the book. So when I look for this, I look for those typical carpal tunnel syndrome symptoms. So if they're having median nerve distribution paresthesias, if they're having some loss of dexterity and nighttime pain, along with that volar wrist pain, I'll treat them just like I treat my carpal tunnel patients. So starting with a volar wrist brace and maybe considering a corticosteroid injection. Trigger finger. So we all know that trigger finger is really at the A1 pulley, but I've certainly seen this cause pain within the volar palm, within the volar wrist, and even cramping up the forearm. So anyone with volar wrist pain, I will look at all of their A1 pulleys along the palm of their hand and their thumb to see if I see any clicking, any palpable nodules, even any pain over that A1 pulley area. I will first start with treating that. So I'll start with a corticosteroid injection at the A1 pulley before treating anything along the hand and wrist. And then lastly, more in younger patients, just a volar forearm muscle strain. See this pretty commonly in patients that are doing repetitive motion tasks, musicians, especially in the younger population. It is a little bit of a diagnosis of exclusion, but if you're having someone with pain up their forearm mostly, a little bit in their volar wrist, I would start with some standard conservative treatments, periods of rest from whatever the offending activity is, hydration for sure, and maybe start with a volar resting brace just to help them along. And lastly, the last mimicker, which is really the big bad of the wrist, which is the scaphoid fracture or chronic scaphoid non-union. I think that this, even without an x-ray, sets off a lot of alarms in your head because you have a young patient presenting with chronic wrist pain, which is fairly uncommon, especially when it's presenting almost like an arthritis. So we all treat patients with knee and hip arthritis. They have some dull, constant pain. It hurts worse when they're walking around, getting out of a chair. Same thing for the wrist in terms of the scaphoid. So they probably have some constant pain along with worse pain every time they use their wrist. Anytime you have restricted motion, crepitus and locking, swelling about the wrist, especially if they even note a remote injury from a few months ago, all of these should set off those alarms in your head that this patient needs an early x-ray just to make sure that we're not missing anything there. So that's it for wrist evaluation for me. I will spend a little bit more time in this presentation on the wrist than I will on the elbow. I'm going to go over a quick review of what I talked about, but if you need a couple minutes break, this might be a good time. If you have any questions, you can start to put them in the Q&A for me at the end. So again, ulnar-sided wrist pain, is it the ECU tendon? Is it the fovea or the ulnar side of the wrist? I like to start with the wrist widget, and then if they need a corticosteroid injection or they need a more heavy-duty brace, I'll try that next. In terms of dorsal wrist syndrome, I like to do an injection initially, therapeutic and diagnostic value, and then I'll put them in the wrist brace and have them follow up in about 6 weeks. Decker veins tendonitis and CMC arthritis. So use your diagnostic skills to figure out which might be the causative problem. And then I like the injection for the Decker veins, and I like this hand-based brace for CMC arthritis. FCR and FCU tendonitis, again, pretty uncommon, but start with a wrist brace. You can't go wrong with that, and then we'll figure it out if it seems to be persisting. But remember your wrist pain mimickers when you're dealing with volar wrist pain. All right, so that's it for the wrist. We're going to move on to the elbow now. As I said, this is going to be a little bit shorter. I think that it's something that people have a little bit more experience with. So starting with lateral elbow or lateral epicondylitis, says the eponym of tennis elbow, even though your patient might not always come in with their tennis racket, as this individual was helpful doing. But they'll show you pain with their wrist extension. They'll show you pain over their lateral elbow. In terms of the anatomy and pathology, maybe a little bit more helpful if you're recertifying for your boards, but it's the common extensor tendon starting at the lateral epicondyle, and it's the ECRB tendon most commonly involved. What the underlying pathology is of repetitive microtrauma that just is not able to completely heal itself. So on my exam, I like to pinpoint where the pain is coming from. Most typically, you'll see it a little bit distal to that lateral epicondyle, which is shown here with the 10 point. Sometimes you'll actually find pain up here in the muscle belly, which I'll get to in a moment, but I do keep that in my mind when I'm formulating the treatment plan. This I find very reliable, pain with resisted wrist extension over the lateral elbow. In terms of how I treat these, managing patient expectations is certainly part of this, and I'll speak about that in a moment. Standard conservative treatments with NSAIDs and rest from offending activity. I like this counterforce brace. I think it does bring some tension off of that tendon, give the tendon a little bit of a rest. If you find a patient that's really having a lot of pain and maybe even acute exacerbation, this wrist brace will keep them from performing that wrist extension motion and really help calm that tendonitis down. You can even use both of these braces simultaneously. I like occupational therapy for lateral epicondylitis. I think that it is helpful. I also think that it's very important for the patient because the patient is coming to you looking for a way that they can help themselves get better. And if you can get the patient involved in their own treatment for lateral epicondylitis, I think it actually is extremely helpful going down the line. This is called a flex bar. So this is something that the patient can even purchase for themselves independently to start working on strengthening of their forearm musculature. I like to quote this paper. It's out of our Academy's review journal, and it's by a pretty prominent hand surgeon who likes to talk about the psychosocial impact of our treatments for different hand pathologies. And I think it's good to tell patients pretty much everything that he writes here. Tennis elbow just happens, unfortunately. It's not that they had an acute injury, not that they did anything wrong. It just happens, especially in athletes in their middle age. And the other thing is, tennis elbow lasts for a long time. It can be very frustrating, and it's good to tell patients that, not to be negative, but to just tell them it lasts for a while and likely it's going to go away. An extremely small percentage of patients with tennis elbow need to go on to surgery. The vast majority will resolve. I think that's another reason why getting the patient involved in their care is important, because likely this is going to go away, and likely they can help themselves do it. So I said I would talk about that pain in the muscle belly. So there's something called radial tunnel syndrome, and I won't get too much in the underlying pathology because it's still highly debated even among hand surgeons. But what we think it is compression along the radial nerve as it's going through that forearm musculature. And it's actually pretty commonly associated with lateral epicondylitis. It can be difficult to tell if it's one problem or the other. So what I do is I just treat both. I'll still send them to occupational therapy, and I like to include nerve glides. So I'll actually request that on the prescription to include some nerve glide exercises. The other main modification for my treatment is not to use the counterforce brace. I'll try and keep pressure off of that muscle belly because if there is some inflammation from that nerve, I don't want to aggravate it. So corticosteroid injections for lateral epicondylitis, traditionally very common. I actually don't perform this very often. I do, from the literature, we do know that there's an early benefit. So in the early weeks, first 6 weeks, the patients who are injected will feel better. But ultimately, after 12 months, patients will do no better and possibly worse than those patients who don't have an injection. There's a small but real risk of tendon rupture, which I think worsens the overall issue. And lastly, those typical side effects also seem to show themselves for these injections. If I am going to do a corticosteroid injection, again, uncommon, but what I'll do is go a few centimeters distal to that lateral epicondyle, show them where that X is, and I'll actually inject deep within the tendon to kind of avoid those superficial corticosteroid injection side effects. So what we do for surgery, again, very uncommon, but just so you have an idea, we'll actually go in and remove that diseased tendon, so you end up with a portion of lost tendon, and then you suture that back together with either just suture or the use of a bone anchor into the lateral elbow. I like to mention this just because I think it's a newer technique that can be helpful when you're talking to patients. So patients who maybe have recurrent lateral epicondylitis, have a lot of fat atrophy, maybe they've had a few injections over their lateral elbow, or maybe just severe pain, I can employ this little muscle flap called an anconeus muscle flap. And what you do is you remove that area of tendon, which is usually rather large in these recurrent lateral epicondylitis, and you flip the muscle up over that defect, and it helps bring some blood supply, which is much needed for that tendon healing, and gives some extra padding over that degenerated area. So I think that's actually very helpful in a certain population of patients. So medial elbow pain or medial epicondylitis, called golfer's elbow. I'm not going to spend too much time on this because it's very similar to lateral epicondylitis. The motion that causes the pain is wrist flexion and pronation. And the way I like to manage these is very similar. I like to send them to occupational therapy. I don't like the counterforce brace for medial epicondylitis, and I'll talk about why in a moment. But I will use this wrist brace, especially if they're having a lot of pain, just to calm that tendon down. So again, just like lateral epicondylitis, there's a nerve that runs around the medial elbow, the ulnar nerve. And if I find that they have pain posterior to their medial epicondyle, right in that ulnar nerve groove, maybe there's actually a Tinel sign. So as I'm palpating, it's causing some paresthesias in the ulnar nerve distribution. Maybe you even see a subluxating ulnar nerve, which is not very common, but it certainly does happen. I would treat this along with their medial epicondylitis. So again, occupational therapy to include nerve glides. I'll maybe prescribe this nighttime cubital tunnel brace just to calm that ulnar nerve down for 8 hours a night. And again, I will not use the counterforce brace, just like I won't use it for radial tunnel syndrome, just to take that pressure off the nerve. All right, onto anterior and posterior elbow. So we'll start in the back, so with triceps tendon and bursitis. So for triceps tendonitis, not very common, but you will see it in avid weightlifters. They'll have point tenderness over their olecranon process, so the tip of the elbow there, and they'll have a lot of pain with any type of elbow extension exercise, push-ups, bench press, anything of the sort. In terms of treatment, standard conservative treatments, I do think it's very important to shut them down from the offending activity. They really need to have no pain at rest before you proceed with the rest of their treatment. Once they have no pain at rest, again, occupational therapy, eccentric strengthening for the triceps and the biceps, that's what helps build and prevent this from happening again. Bracing, I don't typically do for triceps tendonitis. If you're having someone who's having a lot of trouble having that elbow tendonitis calm down initially, you could put them in a locked hinged elbow brace just to prevent them from performing any elbow extension exercise, but I don't think it's usually needed if they can stop the offending activity. No corticosteroid injection for the triceps. Why that is when I talk about complete ruptures, when I see complete ruptures, it's usually in that young weightlifter population, and steroids are a contributing factor. Interestingly enough, this is really a bimodal presentation, so you'll find older systemically ill patients also with triceps complete ruptures. And in those patients, it's usually the systemic steroids that may be a contributing factor. Almost always, these need to be repaired to give a functioning arm again, unless that patient is just too ill to undergo surgery. In terms of bursitis, I think this is more common than standalone triceps tendonitis. It's really any sport can cause this, any repetitive motion sport. Usually it's not so much acute, but over the course of a couple of days, they'll start to notice this swelling occur in the back of their elbow. It's typically non-painful. It's usually a little bit boggy on palpation, well circumscribed, and it can extend into the forearm, even up into this area when it's a little more involved. So I like to treat that just by compressive wrap. So initially, if it's pretty large and swollen, I'll just start with the ACE wrap. And then once it gets a little bit smaller, I'll go on to this neoprene elbow wrap. I think NSAIDs are helpful if they can be tolerated, activity modification. I do not typically aspirate a non-septic bursitis or even a septic bursitis of that, but there are a couple reasons why I don't do that. One, I don't want to expose that bursitis to a skin puncture or the outside world. I don't want to turn it into a septic bursitis. And secondly, for whatever reason, whenever you put a puncture through that skin at the back of the elbow, you have a pretty high risk of creating a little fistula. And dealing with a draining, swollen elbow is much more difficult than just dealing with a swollen elbow. So again, I don't typically aspirate this. I'll wait 6 to 12 weeks with just this wrap and conservative treatment. In terms of surgery for this, there is this continuum of pathology of triceps tendonitis, partial tearing, olecranon spur, which you can see here, and that bursitis. So if they're going to go on to surgery, I'll take care of all of them at once. Just because a patient has a spur or has a bursitis doesn't mean it's not going to get better with conservative treatment, though. So I don't think that you need to jump right to surgery for this pathology. And anterior onto anterior elbow pain. So this is mostly going to be talking about the biceps tendon. So distal biceps tendonitis. This again in weightlifters mostly. It's not going to be as well localized as that triceps tendonitis. So in the triceps, you'll be able to palpate it yourself. They'll be able to point easily to it. This insertion of the biceps tendon is very deep within the forearm. So patients typically have trouble pinpointing where that issue is, although you may be able to palpate along the distal biceps tendon and feel some pain. Pain with resisted flexion is a pretty reliable provocative maneuver to uncover this. Again, treatment is going to be very similar to triceps tendonitis. Stop the offending activity to get them from having no rest pain, and then send them to occupational therapy. Again, hinged elbow brace, not really well tolerated, but if you're having a lot of trouble getting this patient to stop doing the offending activity, that can help. Corticosteroid injection, just not safe, too deep of a tendon insertion to do that. And again, patient expectations here, 3 to 6 months likely until they feel fully better. And then when we're talking about biceps tendon tears, so this is one of the few times in the talk I'll talk about acute injuries. So I think the partial tear is really a diagnosis almost of technology as we get MRIs more and more commonly for acute injuries. So if I do have someone who's having this kind of dull anterior elbow pain after an acute trauma, I will get an MRI. I think that's a good idea. I think it helps you in terms of the treatment going down the line. So again, these patients with the partial tears will present similar to those with biceps tendonitis. If that MRI shows a low-grade tear, I'll treat them exactly the same as I treated distal biceps tendonitis. If it shows a high-grade tear, I'll probably treat them more similar to a full rupture. So when you have a full rupture of the biceps tendon, it's usually in a population of middle-aged males, although it occasionally happens in females as well. A sport could cause it, but I have to say the vast majority of the time, it's typically some activity like they're at work or they're helping their friend move and they have a sudden maybe drop of a large amount of weight causing an eccentric force and rupturing that distal tendon. It can be a clinical diagnosis alone. So if you see this pop-eye deformity, the ecchymosis over the elbow, and you can do this, which is called a hook test. So this is actually showing a normal hook test. So this practitioner is actually hooking the distal biceps tendon as they're dragging their finger across the anterior elbow. In this patient, that finger would just kind of smoothly glide across the elbow, not being able to grab a tendon. So if all of those are found, I don't think you really need to have any further imaging. I do think an MRI is helpful if you maybe have a normal hook test, but you still have an acute injury, especially, and I do think it's especially helpful in chronic tears. So someone who may have had an injury a month ago, but is just presenting you for the first time, that MRI may be very helpful in the diagnosis. In terms of treatment for acute ruptures, I usually recommend repair. You can certainly have a functional arm much better than a ruptured triceps without a biceps tendon, but you stand to lose a substantial amount of strength. So I think usually in the middle-aged population, still working, still doing kind of activities outside of work, they would like to have their biceps tendon repaired. So lastly, a few elbow mimickers. Firstly, arthritis. So I find this a lot in former throwing athletes or maybe current throwing athletes, especially baseball. It can be occupation related, so heavy laborers, and medical related as well. So rheumatoid arthritis patients, I'll typically keep an eye out for this even with a younger age. The first thing you'll notice is a loss of the motion. So typically end extension, end flexion lost first. If I had to pick one, I'd say the end extension is lost first, and it's easily noticeable. The patient will even tell you, I can't do a push-up anymore because my arm just doesn't do that. I have difficulty riding a bike because my arm just doesn't lock out like it used to. I will confirm this with an x-ray just so I'm sure of what I'm going on to treat. In terms of treatment, I think this can be treated very similar to any other large joint arthritis. So like the knee, like the hip, NSAIDs, activity modification, very helpful. Occupational therapy, there can be a role for this, but I usually just have them do a self-directed home stretching program. So every hour or so, I'll just have them do a full flexion, full extension, or as much as they can tolerate, and that's just to keep their elbow from getting stiff. Sometimes that compression sleeve, the neoprene sleeve that I showed earlier, can be helpful if their elbow is very swollen. And corticosteroid injections can be helpful in the treatment. Just like thumb CMC arthritis, I don't typically jump to a corticosteroid injection, but for maybe a patient that I've been treating for a while or a patient that has an acute exacerbation with a known diagnosis, I do like a corticosteroid injection. Steroid injection for the elbow, I think also easily done in the office. You do have to find the triangle of the lateral elbow. So you find the lateral epicondyle, you find the olecranon process. Both are fairly easily palpable. Radial head can be a little more difficult. So what I like to do is place my finger over where I think the radial head is, and I'll actually have the patient pronate and supinate their wrist, and you actually feel their radial head moving under your finger. So once you have those 3 points, this lateral elbow triangle is a very safe place to give an injection, and I think fairly easy to do. In terms of next steps, the reason I show this is because I think the elbow differs from other large joints in terms of surgery. So total elbow arthroplasty is just not at the same place that hip and knee replacement have gone to in the last 20 years. The longevity of an elbow replacement is only about 8 to 10 years, and there's a weight restriction of 5 pounds lifetime. So that's pretty poorly tolerated. On the other hand, there actually is some good procedures to treat elbow arthritis before doing an elbow replacement. So what I call an open joint sparing procedure. This is an interesting procedure where you actually drill a hole in the distal humerus. So where there's been a lot of bony osteophyte buildup, you just remove it, and then you remove some of the osteophytes of that proximal ulna as well. And this allows them to regain that terminal range of motion that they may have lost. Very good procedure for early elbow arthritis. And then lastly, the other few other elbow mimickers. So I just mentioned this because anytime a patient tells me they have shooting pains, or maybe they have lateral elbow pain, but they also have maybe pain within their humerus area or their shoulder area or the back of their upper back, I will do a pretty comprehensive upper extremity exam, including the shoulder and neck. And if I find any positive provocative tests that may lead to shoulder or neck pain, I'll start with physical therapy for those, because I think that the physical therapy is shown to be a mainstay of treatment for both, and that may actually clear up the referred or radicular pain down their arm. So just a brief review of the elbow. For medial lateral epicondylitis, I like occupational therapy. I find it very helpful. Managing their patient expectations is also extremely important. nerve glides if you suspect nerve involvement, radial tunnel or cubital tunnel, bracing, so the counterforce brace for lateral epicondylitis. This volar wrist brace is very helpful if they're having a lot of pain. Cubital tunnel brace, and I typically avoid a corticosteroid injection for these pathologies. Triceps and biceps tendonitis, stop the offending activity. Once that's done, occupational therapy is very helpful. Again, I avoid corticosteroid injections here. I do think an MRI is appropriate for both the triceps and the biceps if it is an acute injury or acute onset. Elbow arthritis, start treatment just like you would treat any large joint arthritis with conservative measures. Corticosteroid is a possibility, and surgical options involve non-replacement procedures primarily. Here are my references for today's talk and the images as well. And now we have time for some questions. I thank you all for joining me. I appreciate taking some time out of your night to hear a little bit about elbow and wrist pain, and I hope that you learned a little bit. So I have a couple of questions here, so I'll start with them, but feel free to add more if you'd like. So first one, 12 to 14-year-old girls who do cheer or gymnastics, growth plates closed on x-ray, sore with wrist flexion and tenderness to palpation along the DRUJ, and with wrist extension and gastro resistance. What can be the diagnosis? So we're talking about kind of a post-adolescent girl, so maybe a young adult here who does gymnastics. I would probably go on to get an MRI for this type of patient just because I worry about a bony abutment problem, or maybe even there's a lot of different pathologies within the carpus that can occur from this repetitive motion. So I typically consider these younger gymnasts high-level athletes, so my level of suspicion for a bigger underlying problem is a little bit higher than the middle-aged recreational athlete that I've talked about mostly today. So I do like early kind of advanced imaging for this to see if make sure I'm not missing some underlying bony anatomy, some underlying bony issue like Kienbach's, or a stress fracture, or even a ligament injury here. All right, another question.
Yeah,
go ahead.
To interrupt you. I just want to just quickly remind our audience that they're welcome to still submit questions. We can go a little bit over if they have any other questions, so just type them into the Q&A box there.
Thank you. Second question. Many individuals automatically blame computer work for wrist and elbow pain and conditions you have discussed. How common do you find that computer is the causative agent as opposed to their sports, exercising, and other activities? That's a great question. I think that occupational pain is a huge part of wrist and elbow pain. And while this talk was geared more towards what you may see in recreational athletes, I think that this is not to be ignored. So I do like to treat them similarly. So if they have those issues while at work, then they can certainly wear the brace while at work. Occasionally, I've made an ergonomic referral. So there's actually individuals who specialize in workplace ergonomics. That's another thing, kind of like occupational therapy for lateral epicondylitis. I think it helps get the patient involved in finding something that is more comfortable for them, helps them get involved in the treatment of their hand and wrist issues. So certainly not something to be ignored. If someone tells me they think their work is contributing to it, I don't tell them that I don't think it is, because I certainly think that their work position can be contributing to it. But ultimately, I'll treat it pretty similarly. Think about occupational therapy referral or even an ergonomics referral. Another question, do you recommend needle puncture release of ECRB tendon as recommended by sports medicine for tennis elbow? So this is a little bit, for those of you who maybe don't know or maybe don't refer as much for lateral elbow pain, so this is something that can be called dry needling as well. And part of it is performing kind of percutaneously what we do with an open procedure, so trying to cause a local trauma to that ECRB tendon, semi-releasing it, semi-causing some increased blood supply just due to trauma to try to bring some blood supply and healing back to that area. I think there is some evidence to this, so I don't think you need to steer patients away from it per se. It's not really part of my practice. I've found more reliable results with an open debridement when it comes to that. But certainly there are a handful of patients who are just not going to comprehend or just really don't want to go through surgery. And this might be that option for them where they can do something a little bit more aggressive while still saving surgery for down the line. So I don't think the evidence is as strong as open procedures. There certainly is some evidence, and I think it's just another tool to have in your toolbox for a certain population of patients. So that's all I have for questions. I'm happy to stick around if you're still thinking of things, but I'd like to be respectful of everybody's time as well. So I'll stick around for a couple of minutes, but thank you again for joining me tonight, and have a good evening.
All right. Thank you so much for your presentation. On behalf of Atlantic Health System Morristown Medical Center Orthopedic Surgery and the Department of Orthopedics at Chilton Medical Center, I would like to thank you for your participation in today's event. You will now be redirected to a post-event survey requesting your feedback. Please take a moment to complete this survey in order to receive credit for providing feedback and attending today's webinar. Again, thank you so much for your time today. This will conclude today's program. Thank you, and enjoy the rest of your day.